I feel like most people don't even have landlines no more, so I don't know who I'm gonna
Nobody has
call
landlines. No,
on.
we do. We do for that reason. So, anyway. So we are on week 5, okay? Next week, we're going to start our reviews again. I will do mine again at next Tuesday at 6 p.m. I'm going to repost that schedule of who does the reviews when, so that you have it in case you want to go. And again, they're all going to be posted. Friday night, I am working diligently on updating, reviewing, and making sure your study guide PowerPoint it has all of the concepts somewhere that you'll be able to understand. Okay. I'm really fine tuning it. It's not done yet. I worked a couple hours yesterday. I'm going to work a couple hours today and tomorrow. Not today, tomorrow, because tonight is my husband's birthday dinner. So I will be getting that out to you Friday night or Saturday at the latest. So you'll have your study guides, you'll have all the Kahoots in one place, and you'll have the review times that you can make your plans. On week 5, we do have our first case study. Take your time with them. You've got to read them. If you don't, there's going to be questions just from reading. You can't go to the answers. Furthermore, you're not getting the information you need. And the discussion question. Most of you got them in, which is great. I'll be putting something posting up there tomorrow of another way of looking at things on the discussion post. If you would just respond to that as you see them. This is a great week to start your project. Okay, make sure you send me what you want to do. I'm getting some very interesting diagnoses, and that makes me happy. I love to be taught new stuff or look at things in a different view or different type of autism or a different type of seizures or these really obscure things. And I really like that. So I appreciate those who've sent in your diagnoses already. And they're all great. So I look forward to doing that. Start with your paper. Okay, it's 250 words. If you send it to me in the email, not posting it yet, because once it's posted, it's done. Send it to me in the email, and I can show you how to write a proper paper. Give me what you think it looks like, APA format. It's a cover page. There is headers on there, page numbers. I'll show you how to put it in perfect format so that when you get to communities paper and if you go on for your BSN, now you've got a paper that you can look at and go, oh, that's how you do citations. That's how you do the references with citations. That's how format it. What is the spacing? How do you space references? I'll do it all for you, but you got to get it to me. Week 8 is everybody sends it in. So before week 8, I can help you. The second part is that diagnosis assessment form. The most important part is the last couple pages where you talk about the child, talk about theorist and how that theorist is with that child. It's also goes into your NANDA diagnoses. Make sure related to as evidenced by. Okay. The paper I think says give me 2. Some people give me 3. It's a difference of instructions. 2 or 3 is fine, but at least 2 references should be on that. Your paper needs references, and then the teaching, which could be a handout, a PowerPoint, and a PowerPoint does not need to be 30 slides. No, 6, 7 slides. Teach me something. Teach me how to give an insulin injection. Teach me how to organize myself for ADHD. You see, it could be simple. It doesn't have to be mind-blowing teaching, okay? So that is with that project. So we're going to start out with PowerPoint, and then we'll be going to the Kahoot. Can you see the PowerPoint?
Yes.
Thank you so much. I've got this 3 screen thing, and I'm still trying to figure the whole thing out. I'm getting pretty good at that. All right. So we're going to do respiratory and cardiac, chapters 40 and 42 for the exam. It's heavy on respiratory. It's lighter on cardiac, okay? So that's cardiac is so difficult. It's so confusing. It's complex. And unless you work with it and touch it and feel it and see it to learn just the symptoms or just memorizing things doesn't make sense. I know I worked in it for over 10 years in just the cardiac unit. And then before that, I worked another 5 or 6 years in the newborn ICU and took care of all of the cardiac. So I'm a really cardiac person. So let's start here. So respiratory infections, they can be two different types. It's upper respiratory, which is your nose, your ears, coughing, tonsillitis, anything that affects breathing. And then the lower has to do with, could be asthma, could be pneumonia, everything down lower, okay? Now, mostly your infections are viruses. You go to the doctor with your child, they have 102 fever and or 103 fever, let's say, and they're coughing and they got a runny nose and you think they have upper respiratory infection and need antibiotics. And the doctor's going to say, "Okay, let's just treat it. We did all the cultures, everything's negative. Let's just put you on fluids, rest, antipyretics." How do you treat any viral infection? This is an important concept. Rest, fluids, antipyretics. Okay, antibiotics don't work with viruses. Okay, it's like taking something and it doesn't do anything. Now, you can have other infections in the lungs, pneumonias with bacterias and this Haemophilus influenza. That's why we take the Hib vaccine for Haemophilus influenza and decreasing incidences of ear infections and pneumonias. So let's talk about that infant. It's something that I've referred to several times, but let's get into it a little bit deeper. Infants are born with mommy's immune system, but that goes away. It goes away, and now the baby's got to make their own immune system. So initially, in the first 3 months, a baby should not be sick. If a baby went to the ER in the first 3 months with a fever, it is a high priority chart because they have no immune system to fight. Okay? So for the first 3 months, the baby should be very healthy. We're giving it our immunizations 2 months, 4 months, 6 months, right? And so we're starting now at 3 to 6 months. Mommy stuff is wearing off. Infections go up, respiratory. Now we're starting to see this child get fevers and getting sick, especially if they're in daycare, right? Daycare is just a place where we swap germs all day long, right? So as we're getting these infections, what's happening? The body's building up its own immune system, producing antibodies and antigens, right? So now that baby is getting more protection because they were sick. True toddlers in preschool, all they do is play. They swap toys, they swap spit all day long, cough on each other, share things. And again, they have multiple infections. I hear parents all the time going into the ER. I just put my kid in daycare, and every week I'm at the doctor's. And why? They're sharing, they're swapping germs, right? And actually, it's a good thing with moderation, of course, because your body is building those antibodies. So again, as we get older, it's going to be more, not viruses usually, it's more that bacterial thing like pneumonias or strep. But we know as our body gets immunizations and gets diseases, our immunity increases. Now, one of the things that bothers children, I think probably one of the worst things, is otitis media. What is otitis media and
Ear
what happens?
infection.
It's an absolute ear infection in the middle ear. How does that fluid bacteria get to the middle ear? Children, they have a eustachian.
Money.
It is short and it is wide and open. And then all the mucus, if that child doesn't blow their nose, which they don't, they like to drip it and lick it, right? So they've got all this mucus sitting there and it's building up and it goes to the areas of least resistance, up the eustachian tubes into the ears. What does a kid look like coming in with an ear ache, ear pain? It's so cute to see this little 2-year-old come in and you say, which ear hurts? and they take the right hand and go over to the left ear, or the left hand and go to the ear, and they point to it. And the first thing that we need to do for that child, if they're complaining of pain, is priority is pain medicine. And you're going to say, why not antibiotics? Well, they have pain. The antibiotics is not going to work for a day or two. So you need to treat the pain. Okay. So otitis media is an infection, it is a bacteria. You always have staph in your mouth and nose, constant. As a nurse, you might even get MRSA up there, and it's just there. It's just part of what it is. So when it goes up into the ear, now you've got bacteria in the ear, so you need antibiotics. The one thing that we need to teach our parents is to make sure that they take all of them. Now, I've had bad ear infections as an adult, and I've had to have tubes put in my ears, just like children. And children get it done in the OR, and I'm really glad for that because I have it done in the doctor's office, no sedation, and I can hear them, put the numbing stuff in, cut it with a scalpel, put the suction catheter in there, and you can feel it go, and they're suctioning. Yeah, it's pretty horrible. And you get a little dizzy, and it's hard to stand up. I have to bring my husband with me. The first time it happened, I didn't have anybody with me, and I couldn't drive home. I had to call Uber. And children go and do the OR, but because they're asleep, they don't feel it as much. And then they have time to lay down, relax, recuperate, get that equilibrium back, and they're okay. And usually there's no pain afterwards. So as I said, those gestation tubes are wide, short, and open, and that's why it happens. And we get all these things. So you get a kid that are sick, ear infection, fever, tummy ache, anything. One of the first things that we see with children is they stop eating. If a kid's not eating and drinking, there's something, especially if it's their favorite juice. Oh my God, you got apple juice and you don't want any? There's a problem. So that's probably what I see first, especially in the younger kids, because older kids deal with things better than the younger kids or the infants. Now, if it's an ear infection, yes, you're going to have pain or a sore throat, strep. Yeah, they do hurt. You're going to see fevers in them. And with that, they're going to stop eating. And sometimes the only thing that we see is they stop eating and they vomit. And then we realize, oh, they have a fever. We know that they can have all of this mucus up in the nose, and that's what kids do. And that mucus does interfere with listening to the breath sounds because we've got to clear the upper airway so we don't hear referred sounds. So we have a kid with respiratory issues. What is our goal? What do we want to see? Well, if they came in and they're coughing and, breathing rough, we want them to breathe easier. So ease that respiratory effort. With children, especially, it's rest, it's fluids, it's, if we keep the antipyretics, we keep a child's fever down, they will be active, alert, and running, but most importantly, drinking fluids to help with the fever. Once that fever goes back up, they're sitting in the corner again. Children are so resilient. I've watched them come in just in mommy's arm and they got a fever of 102. I medicate them properly with a good dose. 20 minutes later, they're running around like nothing ever happened. And that's kids. That's why I love them. And that's what you want to do because then you can get fluids in them. Now, I'm going to tell you a little story about mono. It's a kissing disease. It's not a big deal. Yes, it is. Mononucleosis is a virus, Epstein-Barr type. And Epstein-Barr is a fatigue syndrome type virus. You just feel achy, like flu, achy, and you can't move, no energy, okay? So it is extreme fatigue. But with mono, there's something going on there with that virus, so fever. It's also sore throat with mono, okay? And then you see swollen lymph nodes. You also can get swollen liver and a swollen spleen, okay? Now, how do we diagnose mono? It's actually pretty hard. These children go to the doctor complaining of flu-like symptoms, fever, and sore throat. The doctor does a culture, does a strep test, does a flu test. Everything's negative. So they send them home viral. How do we treat viruses? Rest, fluids, antipyretics, right? So 5 days, 3 days later, they're still sick is, oh, horrible. So they go back to the doctor. And the doctor says, well, everything was negative, but you're still sick. So let's put you on some antibiotics. Not uncommon. And I hear it all the time with kids who come in with mono. So then on Saturday, they come into me because I worked every weekend. So I could go to school during the week. So every weekend I would work. And on Saturday morning, this little boy came in with a daddy. And that was exactly what happened. He went on the doctor on Monday. He went to the doctor on Thursday. He's still sick, doesn't know what to do. He feels horrible. And we listen to his story and we go, there's something that we need to figure out. Is it a virus or is it a bacteria? That's the first thing. And how do we determine that? A simple CBC, right? We're going to look at the white count. Is the white count elevated? And that's a bacteria. Or is it normal? And that's a virus, right? We also, with those symptoms, will be drawing something called a mono spot test. And with all those symptoms, it's positive. Now, that little 9-year-old boy who came in that Saturday morning had all those symptoms, it was a virus, normal CBC, normal white count, and we did monospot and it was positive. So now we know how to treat him. It's a virus, rest, fluids, antipyretics. But didn't I tell you they can get swollen glands, swollen liver, swollen spleen? They can explode if we put too much pressure or they're hit, like in contact sports. What is a nursing care? What do we teach that child? Number one, no physical activity, no PE until cleared by your physician. So no rough rousing with the kids at home. I had 6 brothers. They'd be, beating me up all the time. So you have to tell the brothers to go away and protect the abdomen. Well, let me tell you about that 9-year-old boy. I gave him great discharge instructions, written instructions, and even the physician I was with was a really good one and really gave him good instructions. Basically protecting that abdomen, no PE, that was our major concern, and just rest, fluids, antipyretics. 1 week later, I am primary trauma nurse on, which means any copter that comes and lands, I am in charge. I do the documentation, I make sure everything's there that I need, and I get a call. Kid out in the Everglades fell off a 3-wheeler and is coming in on rescue. It was my mono boy. He was on a 3-wheeler out in Homestead in the country, fell off on his abdomen. They called rescue. He came to me and he was dead on arrival. A 9-year-old boy with mono. So, moral of the story, teach your children, your adults, have mono, please protect the abdomen, no rough housing, because it's like a big balloon that can just explode and that's the end of it. So bronchitis, it's your bronchus, your trachea and your bronchus gets inflamed. And this, I think, is one of the most annoying things that can happen. It's just this dry, hacking cough, non-productive, and when you want to sleep, it gets worse. So these children usually don't have fever. It's just this big, usually cough. And we usually will take, analgesic, which is Tylenol or ibuprofen, right? We'll take those because of the pain. But we're going to do maybe a cool mist, right, on these children to help. And cough suppressants, cough drops, cough medicine, if you can find it. Again, bronchitis, dry, hacking cough, non-productive. It's worse at night. Now, croup. This is now the larynx, the trachea, and the bronchus. So it's more the whole oral airway down almost into the lungs, okay? And it inflames. And the trachea gets swollen. So if you try to get air in, it's an inspiratory stridor because it's upper airway. You're going to hear me talk about inspiratory and expiratory stridor. Croup is inspiratory. It's upper respiratory. I can't get air in. So this child, what would you see? This child is going to be coughing, and it sounds like a seal. And when they breathe in, you're going to hear, because they can't get it in. It's most commonly, again, caused by H influenza. Again, that vaccine is very important to prevent these things because croup can turn into a lot more, okay? It is a virus. It's treated with steroids. It's treated with albuterol just to decrease the inflammation in there, okay? Again, if we don't take that inflammation, that swelling, which air can't get in, you slowly become hypoxic and acidotic, and of course, you could die. Also, it could turn into acute epiglottitis. What is epiglottitis? Well, croup is the larynx swollen, right? With epiglottitis, the epiglottis, which is a leaf-like structure that covers the trachea, when you swallow, it gets swollen all over the trachea, so air can't go in. You have no airway. Inside, you can't get air in. Usually, there's a small space somewhere in there. So you hear, and that's the way you talk, like you can't swallow secretions. They're leaning over in that tripod, like that old lady tripod position, that COPD, like trying to struggle and breathe. This is a true and real medical emergency. This child, if I saw it, would be into the trauma room. Respiratory would be called, and I'm going to have a trach and an intubation tray at bedside because many times they cannot breathe, and you've got to provide an airway. So, how do we treat epiglottitis? It's an inflammation, it's a virus of the upper airway. We've got to decrease it. So, number one, you've got to find out where they can breathe. Now, children, when they can't breathe, I mean, even adults, but specifically children, because that's what we're teaching, when they can't breathe, they become a little hypoxic and they get restless. Okay. So they also get really scared. So, how are we going to take care of this child? Number one, calm them down. They want to sit on mommy's lap on the floor. I don't care where you want to go. If they're calm, they're breathing easier. You have less chances for problems, right? That's keeping the airway open, elevating the head of the bed, giving them a pillow to lean over, whatever you need to do, whatever that child wants, keep them calm. Then we're not going to worry about oral or IV hydration immediately, but we might need an IV in order to get IV steroids in there. Solumedrol is the drug of choice at this point in time. Also, nebulized epinephrine. We call that racemic epi aerosols. And that's the epi going right into the swelling, decreasing it, and letting them breathe. So, what do we know about epiglottitis? Emergency, swollen epiglottis, air don't get in, inspiratory stridor, upper airway. Now, this is a thing that most of you have heard about. It's RSV. And for you and me, it's a common cold. For a baby, it's a little bit more. And let me tell you why. RSV produces mucus in the nasal and oral pharynx airway, right? It's a lot of mucus. And it's a low grade fever, like 100.8. I mean, 101 maybe, but it's not these big 103, 4 fevers, just low grade, just enough to feel a little bit horrible, okay? Babies are obligatory nose breathers, infants, first year of life. So they've got mucus in their nose. They can't suck, swallow, and breathe. Okay. Now, it is a virus. So treatment is rest, fluids, antipyretics. Okay. And with this RSV, it's clearing the airway before we feed them so that at least they have a chance with it. Now, babies can tolerate this. Common cold, suction their little mucus out of them. It's fine, right? Take care, of a little Tylenol, they feel better. Now, what if you're cardiac or you're cystic fibrosis or you have some other immune problem that your body doesn't handle stuff like this well? And that little bit of problem with breathing can put them over the edge and, cause major issues. Well, we can give an immunization. Now, there's new things out that says they don't do this, but our book says it. It's still on our testing that we're going to be giving a monthly immunization called Synagist, and the generic name is palivizumab. It is a biologic. Once a month from winter to early spring, only the first 1 year of life. Because after that, babies can blow their nose easier. They don't have a problem with sucking, swallowing, and breathing. Okay. Now, tonsillectomies, most common of all surgeries for children, right? Children, it's usually tonsils, adenoids, and tubes all at the same time. All that mucus going up, sore throats, ear infections, and it gets to the point where they've got to just go ahead and take them out. Kids snoring, have apnea, all these things are reasons why we take it out. Frequent sore throats, etc. Now, think about what a tonsillectomy is. You have to think about that first. They have these big round nodule things in the side of the throats, right? They take a scalpel and a cauterizing tool and they cut that tissue off and cauterize. So what is left in the throat is a scab, okay? So think about, you have a scab on either side from the tonsils and adenoids that have been removed. So post-operatively, how are you going to treat it? Yes, it's uncomfortable, okay? I had my tonsils done at age 22 or some crazy thing, and it is uncomfortable. It hurts. It's like burning there. Not horrible, but it hurts. Avoid those irritating spicy foods like lemons and limes and orange juice. It'll just burn like crazy in there because of the scabs in there. You're not going to do anything gargling and toothbrushing and anything that could remove the scab from back there. And I'm going to tell you why. I had a 7-year-old girl come to the ER she was 7 days post-op, just went to the ENT and had a clearing. She had TNA and tubes put in. And on the way home, she vomited blood, a big clot of blood. So they carried her into my triage. Of course, I'm in the triage room. And I give her a bucket, and she's these big, look like liver clots. They were so big of blood that she was just puking. Well, I looked at her. She was weak and limp. I'm like, I'm not treating her here. Immediately, I picked her up and brought her into the trauma room, got help. This 7-year-old girl took a liter of normal saline just to maintain her blood pressure. Her blood pressure was 60 something systolic. Heart rate was 160. She was hemovolemic shock, and I had to give her saline for it. So it can be a big thing. And these kids go home after surgery. So again, making sure we don't touch and manipulate there. Now, one of the things that kids do is they put ice for pain. Now, young kids won't use it. They're like, ooh, it's cold, get it away. But older children will put it on, and that ice on the neck is very comfortable, okay? Older kids also, because of the eustachian tubes and the work in the back of the throat, ear pain. I mean, even younger kids, they get it, but older kids can chew gum. Why gum? Have you ever gone up in an airplane and your ears pop and they tell you to chew gum or open your mouth and yawn wide? It's the same concept we're doing here. We're trying to get the air free in these eustachian tubes. So chewing gum can help with ear pain. Now, we expect a little bit of not great breath after surgery. There's 2 scabs back there with blood and whatnot. So it's really expected to have some pain, a little fever for the first while. If it continues or the breath becomes worse or the pain becomes worse, then of course they need to be seen by the physician. So we've talked all about the upper stuff now. Let's talk about some lower respiratory. And we talk about lower, it's the pneumonias, okay? Pneumonias could be inhaled, it could be aspiration, or it could be just a block of some bacteria that's sitting in the lungs. You can have viral pneumonia also, okay? So there is a pneumococcal vaccine that we give now, because that was one of the big type of pneumonias that we were trying to take care of. So that is actually given very early. The other pneumonia that we don't think about is, in children, it's very real, it's aspiration pneumonia. Children always have reflux and always burping up and down, right? And we've got to teach our parents how to feed a child so that they're not going to aspirate that much. Okay. So we need to make sure that we don't overfeed, that we burp them properly, we sit them up after they feed. And, it's this overfeeding that tends to cause all of that reflux. So, again, making sure they're feeding them right. The other way that they can get aspiration pneumonia, and you too, is chemicals. I've actually seen, I remember one student was cleaning her bathroom with Clorox and Ajax or something, and she inhaled the chemicals, and she had an true and real aspiration pneumonia. So adults can get it. Can you imagine how fragile young kids' lungs are? So again, those sort of things can cause an aspiration pneumonia. The thing kids do is put everything in their mouth, right? Let's explore the world, put it in the mouth, and chew on it. Well, one of the most common things that kids like to do is put coins in their mouth. Do you know what coin is the most popular? I've seen at least 20 of them. What's the most popular coin, do you think
A
a
penny?
child would put? No.
A quarter? Wow.
Always a quarter. I think I've seen one nickel. I'm serious, quarters. I don't know why they do it. Now, how do you think we get that out of there? Years ago, we used to send them to the OR, put an IV in, sedation, anesthesia, do a bronchoscopy, and pull it out. So it's this whole big project, and usually sometimes overnight stays. And it really doesn't need to be. These children usually come in and they're drooling because they can't swallow, and it hurts, because they feel it there. But usually their airways are okay, because you're always worried about the airway. When I first saw how it was done and how they took that out, I was marveled. What happened was this little 3-year-old boy swallowed, and it looked just like that. That's his picture right there. And the surgeon came down and asked for a Foley catheter and blew up the balloon, made sure it worked. And what he did was put that boy on his lap, put that down his mouth, the Foley catheter, very slowly, blew up the balloon, leaned forward, the child, pulled it out, and it came out and he vomited. Now, how did I keep that kid calm? I said, when that quarter comes out, whoever gets it first can keep it. So I want it. So now this kid's, what is he thinking? Oh, when the quarter comes out, I want to get the quarter. She's going to get it, so I got to get it. So now his mind's not thinking about what's going on here, is he? And I'm telling you, as soon as I pulled out, the doctor pulled out that and the quarter fell out, the kid was on the floor grabbing his quarter. All's good, wasn't it? And then we just monitor them afterwards. I have seen French fries literally kill a child because it got into the bronchus, into the airway, and they were placed on ECMO, the machine like a heart-lung machine, but it's just for respiratory. So aspirations are a big deal with kids. So small toys, safety, that's always we'll be worried about. Now, pertussis is a disease that we do have an immunization for. Not everybody gets immunized. It's unfortunate because pertussis is extremely, extremely infectious. I mean, we treat it with azithromycin. We put them in respiratory airborne isolation because it goes around quickly, and it's really, really hard on the younger kids. Again, there's a vaccine, and we should promote them. Smoke inhalation can happen. Again, how do we treat it? This is like maybe there's a fireplace and there's no vent, and now the smoke's going in or whatever. We treat it with like 100% oxygen. Again, it's airway, keeping the lungs okay. Smoke and children should be avoided completely from the time of pregnancy up till they're older. One of the big issues with smoke is SIDS death. That's the big one. And number 2 is otitis media caused by environmental smoke. So again, we shouldn't be smoking around them. Cystic fibrosis. What is cystic fibrosis? There's several questions on the exam about this. This is an immunosuppressed disease. And what it is there's all this mucus that goes into the lungs and into the intestines, and you sweat. Electrolytes come out of your skin, and it is something that is maintained. It's not cured. So, how do you know if your child has cystic fibrosis? Well, if you've done the test, prenatally, you would know. But what if you didn't or couldn't get the other person's whatever? And now you don't know. What would you see? The first symptom of cystic fibrosis is no stool for the first 24 to 36 hours after birth. It's called a meconium stool, okay? So when we have a child that doesn't move their bowels in that first day or two, we'll be testing them for cystic fibrosis, okay? We do it with a sweat test. Now, as they get older, what are we going to see? Well, as I said, electrolytes escape through their skin, and it's the salt. If a parent licked their child with cystic fibrosis, they're going to taste salt. Absolutely. And it's really strong salt. And because there's all this mucus in the airway, thick, like a petri dish thick type mucus in the lungs, they're always going to be coughing and trying to get that airway going. And because of this petri dish mucus, it's growing bacteria and all sorts of bad stuff in there, okay? You're going to hear every breath sound, wheezing, shortness of breath, rales, rhonchi, all of that stuff, because it's all that mucus in there. Now, the third part of cystic fibrosis, so we have skin, loss of electrolytes, 2, lungs full of mucus, 3, it's your small intestines, does not produce an enzyme that can digest. So if you can't digest fat, what happens? Well, it just comes out the other end, greasy and nasty smelling, like foul smelling, okay? Also, you're losing all your fat vitamins. Those are the things that we worry about with cystic fibrosis. Maintaining their electrolytes, keeping their lungs as clean as we can, aerosol, CPT every day, all the time, multiple times a day. And then we need to make sure that that child can eat and absorb some of the nutrients. And I'm going to go into how we do the nutritional part of that. Because if they're not eating fat, they're not going to gain weight. Do you remember in nutrition what had the highest calorie content? Carbohydrates, proteins, or fats? Fats are double carbohydrates or proteins. Carbohydrates and proteins are 4 calories per gram. Fat is 9. So you see it's double the amount of calories and stuff. So these children have a problem with weight gain because of that. So as I said, that meconium ileus at birth, which means no stool, could be cystic fibrosis. If we see that, we can just do what we call a sweat test. It's really easy. They put a probe on the skin and they measure sodium. It's not even a lab test. It's not sticking anything, putting it on and measuring it for it. So how do we treat cystic fibrosis? Well, we've got lungs. They're going to be infected. So we're going to have multiple antibiotics. This child will be on PICC lines all the time. Multiple IV antibiotics at home. And again, with antibiotics, we got to be careful with all those side effects and lung, liver, and kidney function and hearing and all those things, okay? We also are going to be doing, before we eat, we're going to give an aerosol, albuterol, Preventol, Ventolin, whatever the name of it is, that just keep it open, make that airway open. After the aerosol, we will give chest CPT. We can do it with our hands and clap, or we could put a vest on. I mean, the young kids, we put vest on it, and it vibrates it. And then we have them cough and try to expectorate as much as they can. That is with that. Now, also, we have dietary problems, right? We don't absorb fat. And because we don't have pancreatic enzymes enough to absorb and break down the fat to make it usable. So we're going to be giving pancreatase, a pill, immediately before we eat, not 2 hours before, immediately before we eat. Some children, because they can't take the pills, we sprinkle it on their food, and that's okay. That little capsule things, and they're usually like little round beads. They're called enteric coated, so no crushing them, okay? Because we don't want to do that. If it's the powder and we put it on the food, we've got to make sure we rinse the mouth out, just like we do with some of those aerosols, the Symbicort, Advair, Brio. We want to make sure that we rinse the mouth afterwards. Same concept. So that powder, we got to make sure that. Another thing about medicines and children's globally, children grow. Some years they don't grow much, and some years they grow like weeds, right? We've got to make sure that we adjust doses as they get bigger. Whether it is the simple just pancreatase to help us eat better, absorb our stuff, or something for seizures. It's making sure we are increasing the dosages as we grow. So, respiratory management. Keep it clear, give bronchial dilators, physical exercise. You know what probably the best exercise for this is? Swimming. Think about it. Hold your breath, go underneath. You've produced PEEP, pressure, open your lungs. I think it's one of the best forms of exercise, and it doesn't hurt as much as walking and running and stuff. Also, we're going to be treating those infections, they also will give like tobramycin, gentamicin in the aerosols. Again, it goes directly into the lungs, like that racemic epi. We do things like that, and it does work. These children learn how to do it. They know when they're getting sick. They start their own stuff, call the doctors, and the parents become great at this. As I said, that GI problem, I think, is one of our biggest things, right? Because we're not getting calories. And if you don't get proper nutrition, what happens? Well, you're not going to grow right cognitively. They're not going to be right. So again, we need to make sure that their nutrition is the best we can produce. So we're going to be giving those enzymes to try to get as much of that fat as we can out of the diet. But we're going to make sure that the other two groups that we can use, protein, carbohydrates, or calories, are at the max. We're going to like give the best that we can. If there's any problem with reflux or constipation, of course, we're going to be treating those aggressively. Some of the problems that can occur because of cystic fibrosis. Remember I told you it's a pancreatic enzyme that's lacking. So if a pancreatic enzyme is lacking, what do you think about with the pancreas? You think about diabetes, right? The islets of Langerhans, right? So it can affect them. Children with cystic fibrosis can become diabetic as they get older because of all that damage there, okay? And as I said, our biggest thing, about the food and not is all about making sure they get enough nutrition and gain weight as well as they should. Another thing with cystic fibrosis is pregnancy. And the reason why we talk about it is women can get pregnant, high risk, high risk. But what about the man getting that woman pregnant? Well, men get mucus in their vas deferens, and they can't get the sperm to the woman, so they cannot have babies. But if they have a bilateral lung transplant, 1 year later, they can get the woman pregnant. And you will see men doing that in order to have a child with their woman. So that's men can have a baby, but they've got a double transplant. Women have no problem. As I said, sleep apnea can happen in kids. We know that it's just like adults. We're going to do the same thing. We hear the snoring, maybe some apneic episodes. We're going to be doing that sleep study. Maybe I'll put them on BiPAP at night because good sleep is what we need. It's not just old people that snore or fat people that snore. Kids can also, and again, not getting proper rest can make a really child that's really not happy. ARDS. ARDS can happen for many different reasons. It can happen if you were drowned. Even if you drown, you come up and then you wake up and are running around, but you were down and out, they're going to admit you in a hospital for 72 hours because the chances of your lungs saying, oh, they were injured and have a reaction later, this is what happens, and they go downhill really, really quick. These children be admitted to at least a step-down telemetry and placed on a monitor with a O2 sat monitor to monitor their respiratory status. Lungs can be hurt because they were ran over, cars, fallen off things, drug overdoses, and of course, overwhelming sepsis, of course, can go to the lungs. So ARDS, once a child or an adult gets acute respiratory distress syndrome, this is your sickest kid, sickest adult. That thing that you're looking at right there, that picture, that is ECMO. I actually was certified in ECMO. And let me just tell you what that machine does. It just takes blood out, it oxygenates it, keeps it thin enough to be moving, and puts it in. It has nothing to do with cardiac output, has nothing to do like the heart-lung machine. It's only lungs, ECMO. And nurses run this machine. It's a lot of fun, actually, to do it. Remember, you're always going to see some sort of question about CPR. Remember that there's, one man and two man. And also, the other thing that we see with CPR is choking, making sure we know how to back flap and abdominal thrust on children for airway obstruction. Those are the things that you will see. The other component of CPR is remember that there's parents watching their kid code, or grandparents, or aunts, or uncles. Somebody's there. Make sure that we get someone there giving them updates. If a child in CPR dies, wouldn't you want that mother holding that child's hand instead of outside somewhere getting reports? That was always my opinion. Get the mother in there, but put her in a place that I can keep her from being, in the way. And most parents thanked me. They were there. They could hold their hand. They could kiss their child and say goodbye. Okay, asthma. Probably one of the most common childhood illnesses, right? It is a hyperresponsiveness, some antigen hits the lungs, whether it's grass or animals or foods, anything that creates this tightness. Now, asthma is a lower airway problem, which means air goes in fine. Once it goes in there, it gets trapped and it can't get out. So it's expiratory wheezing, okay? Upper airway, inspiratory, lower airway, expiratory. It's like, my husband went into status asthmaticus, and the only breath sound I could hear was that's all I could hear at the end of a breath. So again, asthma. How do we treat it? Kids, many of them will grow out of it, but we need to make sure that we keep them safe. So we're going to make sure what's their lungs like. We're going to be testing them for their allergies, trying to maybe get them desensitized to those things, especially the ones that are really brittle and go into asthma, and it can't break the asthma, so we call that status asthmaticus, okay? What do we use for asthma? Well, you've got to do something to make that inflammation of the upper airway and lower airway. We need to relax everything. So we're going to be giving them aerosols. Albuterol, it's a rescue, right? Probably racemic epi if it's that bad. We're going to try that too. We're going to be giving those inhaled morning and night, like Atrovent or Symbicort, that little bit of something to help calm the lungs down. We're going to be giving corticosteroids, Solumedrol, IV usually. And all of this stuff hopefully will calm the lungs down. But many times it doesn't. My husband ended up on BiPAP. He ended up on an aminophylline drip, maxed everything out for 12 days. It's probably, I learned a lot with that one. Status asthmaticus, our goal, number one, anything respiratory, first thing nursing care, calm the child down. When my husband would go into these attacks frequently during the day, I'd hold his hand, I'd look at him, and I'd say, look at me. It's okay. Take a breath. And I could talk him down. You could do that with children too. All right, let's do our first Kahoot. Any questions so far? Can you see that? Beautiful. Thank you. I like the nodding heads. I appreciate that. Who wants to win today? Anybody? Ah, Mackenzie. I think Madison does too. And I think Tamara there is ready for it. All right, let's get going. Kahoot. A majority of upper respiratory infections are caused by what? Remember, most upper respiratories are viruses. I mean, rarely do they come out to be bacteria. That's more than pneumonias, etc. Um, and how do we treat viruses? Rest, fluids, antipyretic. We just call it symptomatic care. That's what it's called. Supportive care. You walk into a 6-year-old room and you find him not breathing and doesn't wake up. What are you going to do? Gotta know 1-man, 2-man CPR. What do you do first? What do you do second? There are always questions on exams, HESIs, and NCLEX on this. So years ago, we would give 2 breaths, right? But today we've realized that people on the street wouldn't stop to give breaths and people would die because they didn't want to put their lips or didn't have something to do that. So they found out through research that just giving compressions, there's enough oxygen in the body. They don't need those breaths. I mean, sure, they could be nice, but it's not as required. So again, we're going to be giving chest compressions. 30 to 2, right? Die. How would you administer cool mist to a frightened child? Got a kid with bronchitis, and it's a 2-year-old, and you need to give them that moist, cool air because it'll help their airway. How are you going to do that? That's that stuff blowing there. Or they put this big plastic tent over the bed, and they got to get inside of it. So, number one, you get a kid who's frightened. What's the first thing you do? Whatever they want to calm them. Put them in the mom's lap, put them on the floor, sit in the chair, not the bed. Doesn't matter where they sit, right? As long as you can do what you work you need to do, it doesn't matter, okay? And again, on mommy's lap and have mommy and them take breaths, let's make it fun. You take a breath, I take a breath, you take a breath, and fun, and make it a game, and the kids will go do it. They're multi. What are some signs and symptoms that smaller children may exhibit that has a respiratory infection? Children that are sick, number one, we see them, number one, stop eating, stop drinking. That's probably the first thing we see. And then we start to see them just regressing, right? I don't feel well, regressing, being quiet, not playing. You check. Now now they might be vomiting, their tummy might hurt, and they have a fever. So when we see this sort of thing and they have a fever, our first goal, as long as the abdominal pain isn't some acute surgical thing, or we surmise that, it's just a normal in the belly button pain type thing. We are going to be giving them their acetaminophen or ibuprofen. And as I said, as soon as that fever comes down, all of a sudden these children will drink fluids, which is what we want. Because you need fluids with a fever. They're multi. What do you look for when assessing respiratory function? With children, you can just look and you can see when they're in distress. Well appearing, sick appearing kids. It's very easy. So when we're looking at respiratory, it's a little bit of everything, right? We're looking at how fast they're breathing. Is it difficult? Are there retractions? Infants, how do you know that they have respiratory distress? They have nasal flaring, okay? And you're going to see them, and you'll see almost bobbing, but it's that nasal flaring. And then at the end of a breath, you hear, it's this grunting and this nasal flaring. This is an infant who's about to code. This is when respiratory distress is at the peak and they need to be treated immediately. So that's infants, nasal flaring and grunting. Older children, it's more, you might see nasal flaring, not as much, usually intercostal and supraclavicular retractions, and of course, tachypnea, tachycardia. What you look for after a child has a tonsillectomy? What are you worried about? So tonsillectomy, you took the tonsils and we cut them out and cauterized the sides of the throat. Our biggest concern is bleeding and airway, right? If we have a child who's swallowing a lot and you're noticing this, why are they swallowing? You didn't give them anything to drink. They're dripping blood in the back of their throat. You would just now, you put nothing in their mouth, but open their mouth, you can probably see blood on their tongue. How do we treat like that child who came into my ER vomiting clots of blood? How do we treat it? They go back to the OR and they cauterize it again and stop the bleeding. That swallowing is telling you blood. How do you position a child post tonsillectomy that's still pretty drowsy? We put them on their side so that it can drip out any blood that comes in and we maintain the airway that way. Nursing care for a child status post tonsillectomy include So when we're talking about tonsillectomy, number one, pain medicine. Years ago, we used to give them more of a narcotic pain medicine. Today, we realize just a little bit of acetaminophen is all they really, really need. It's uncomfortable, but it's not like horrible painful. We do give gum to the older kids because of the eustachian tubes, because of the ear pain. It's like going up in the airplane. It helps it pop and open and prevent and helps that pain. And also, older kids, the younger kids know a nice ice pack here on the neck can help with that pain. It goes and it works really nice. The other multi. What signs and symptoms would you see in a child with otitis media? So, ear infections don't always have a fever at all. I've had multiple ear infections. I mean, like where pus is oozing out of the ear bad, eardrum break, never a fever. Okay. If anything, very minor. What do you see with an ear otitis media? Number one, it's pain. It hurts. That's the biggest thing. And if a child hurts, you're going to see them lose their appetite and sit in the corner, and they might even with abdominal pain and all that stuff because they hurt so bad. It'll be a part of it. You might see, as I said, burst eardrum can put purulent, serosanguinous type drainage out of the ear. Priority treatment, pain. Multi. What would you suspect if a child has a dry, bothersome cough that keeps them awake at night? Which one is that? So, dry, bothersome cough is bronchitis. It's an inflammation of the bronchus. As I said, you cough so much you hurt. Your throat hurts, your ribs hurt, your tummy hurts from all of this coughing, and you're tired because at night is when it gets the worst. Again, it's called bronchitis or tracheobronchitis. It's the trachea and the bronchus, which is called bronchitis. The monthly immunization for RSV is. I gave you all a handout on respiratory and cardiac, giving you the drugs and the conditions. It is a great tool for studying. I'm going to send you the answer sheet after class tonight. So Hib is for Haemophilus influenza, right? Preventing ear infections, etc. That's not RSV. Humira is for like rheumatoid arthritis. Indocin, indomethacin is actually an NSAID, and it's used for next chapter for a PDA closure. And what do we do for RSV? It's called Synagist or palvizumab. And it's monthly, only first year from winter to early spring. A 4-year-old child's been taking meds for asthma and they're still wheezing. What information is important? What do you need to know? Why are they still wheezing? They're taking their medicine. So many times, and it's not uncommon. I've seen it in the adult world because I've done adult ER, I've done pediatric ER. I'm one of those weird people that's done a little bit of everything. I've seen adults come in, they can't push it and inhale at the same time. It's like walking and chewing gum. They cannot perfect it. So this little spacer is a mask that goes around the face, and you put the MDI in the back, and it's a clear tube and you squirt the dose, 1, 2, whatever it is, and you hold it to the face. They cry, they're taking deeper breaths, so they're getting it more. But what they say is just to breathe it in and out like 4 or 5 times, and you've got the medicine. And it works. And like it's very hard for many people. An 8-month-old with croup exhibits what signs and symptoms of respiratory distress? An 8-month-old. So let's look at this very realistically so that you can look at these type of questions. An 8-month-old respiratory rate of 25 is too low, which probably is going to be 30 to 40 normally. And a heart rate of 108 is actually just normal, basic. It's not showing respiratory distress. So that's out. Pulse ox of 95%. Below 92 would be something that we would be concerned in children. Abdominal breathing, okay, could be, but heart rate of 100, no, it'd be 150 if it was respiratory distress. So all you're saying is that substernal retractions and restlessness. Yes, very good, guys. Signs and symptoms of asthma include all except. So asthma is an irritation. It creates a tickle, which causes inflammation and a cough. Okay, that's the first thing. Absolutely. They're short of breath and they have wheezing, and it's called expiratory wheezing. So they have a prolonged expiratory phase. And I'm going to tell you why. When that air goes in and gets trapped, they have to to get the air out, and that's that wheeze coming out. So it's prolonged, not shortened. What positioning helps oxygenation during an asthma exacerbation? I'm going to say wherever is comfortable for the kid, for sure, right? I've had children want to sit on the floor with the parents, or sit on the couch, or sit on the chair. I don't care where they sit. As long as I can give them their medicine and I can treat them and they're happy and comfortable and quiet, they're less restless, they're less hypoxic, and life is better. So high fallers will always be. If this is a child that doesn't know, that doesn't need to be on mommy's lap and whatnot, make sure that, first of all, that they've got a good airway and that they're sitting straight up. That is what your first thing is to do. What should you not do to children diagnosed with croup and epiglottitis? Well, what's croup? It's upper airway problem. What is epiglottitis? Upper airway problem. What aren't you going to do to all this extra swelling in there? We're not going to open the mouth. We're not going to touch it. We're not going to do anything that creates more swelling. Leave it alone. It's even with tonsillectomies, nothing in the mouth. Nursing interventions with a patient with epiglottitis would include what? Got a child that's drooling, that's got that frog-like voice that's coming out, and you could see they're just hypoxic and restless, and they're you could see them. So, what's your thing with epiglottitis? It's upper airway, it's covering the trachea, so you don't have an airway. So, what's priority? Airway. Which here is the priority? Intubation or a trach tray at the bedside so that we can get that airway open, okay? That is intervention. It's not nursing care. That's something we need at the bedside. Nursing care is to get them into bed, get them out of their bed elevated, get them calm in any position they want to be, so that now that we've calmed them, and we have that tray at the bedside in case we need it as we're giving aerosols or doing whatever else we need to do. Which triad suspects epiglottitis? What do you see? So again, epiglottitis is upper airways, the epiglottis. It has to do with the throat. It's the swelling. I can't swallow. I'm drooling. I got that muffled voice, all of these sort of things. Very good, guys. Polydipsia, polyphagia, polyuria, diabetes mellitus. Multi. Treatment for infectious mononucleosis. Mono, kissing disease. How do you treat it? So rest, fluids, antipyretics. Okay. Mono is an Epstein-Barr-like virus. No antibiotics. When doing an admission on an infant with a low-grade fever and a loose cough, what information is important? What do you need to know? You're admitting an infant. So I'm admitting a child into the hospital. I need to know patient replacement. So I need to not only concerned about this infant, I got to worry about where I'm putting that child. So number one, I want immunization status. I want to know because I don't know what their upper respiratory or fevers come from. It could be pertussis, right? So again, immunization status is important. Then, of course, I want to know any meds the child had, acetaminophen, ibuprofen, so I can continue them, or if they were on antibiotics at home or anything, I need to know, or any home medicines that they're on. And of course, I want to know where their fever was. What's the number? I can actually tell you a fever between 101 and 102 and a cough is usually a pneumonia. It's always that type of fever. It's the 103, 104 that is your viruses. The 105, usually they're viruses. How is cystic fibrosis identified? So cystic fibrosis, we can either identify prenatally, they do blood tests on the mom and dad, or at birth, there's a meconium ileus, or no stool, for the first 24 to 36 hours. And we will be testing. One of the things we test for is cystic fibrosis. The other one is hypothyroidism. The other one is a Hirschsprung's disease. So there's things where no stool at birth, very important concept that I'm going to even go more week 8 on you with that. And actually next week again, too. Multi. A male wants to be able to have children with CF. How is this possible? So he has cystic fibrosis. He's with a woman. He wants to have a baby. Remember that vas deferens is thick with mucus, and he can't. Can he now? How can he? So when we talk about a woman, it's no problem being pregnant. They are high risk, of course. A man who wants to get a woman pregnant who has cystic fibrosis will have to do a bilateral lung transplant. For some reason, somehow, 1 year later, they're able to have a baby. I don't know how and what that happens, but that's what the information shows me. Another multi. What is included in the plan of care for a child with cystic fibrosis? You know, when you think of cystic fibrosis, remember it's 3 different things. It's the electrolytes in the skin, it's the lungs, and it's also the intestines and nutrition. Remember that. All of those things play into cystic fibrosis. So, lungs, aggressive CPT, aerosol CPT, also teaching them to clean their equipment every night, all that mucus that comes in it to prevent infections because their lungs are petri dishes waiting for it. Also, because of their diet and their fat problems, they're going to be getting pancreatic enzymes with meals, not 2 hours before, with meals, okay? And then, of course, high protein, high carbohydrates. And we're going to give them a salt shaker. They're losing sodium through their skin. So it'll be a normal sodium diet and extra if they want it. What medication would you hold for an infant that is vomiting? And the vital signs are 98, 88, 32. Let's see if you know this one. So an infant has a heart rate of 88. What should be a normal infant's heart rate? Well, it shouldn't be below 100. That's the lowest that I would say an infant is. What is the medicine that affects the heart rate? And it is digoxin. I'm going to talk more about it in next chapter, but digoxin is probably one of the most commonly used drugs for children, infants, newborns, and it's used very effectively and safely. Remember, it slowers and strengthens the force of contraction. So we would have to do all the things we do in order to give digoxin to an infant, child, or to an adult. Same process. What information is important when rheumatic fever is suspected? I want to talk more, but I want you to start thinking about rheumatic fever. What is rheumatic fever? This is another sore throat. This is a strep infection that attacks the body. So with rheumatic fever, it's a sore throat, okay? It's a strep throat. But what happens is the strep, whether it was treated, not treated completely or not treated at all, this strep goes into the body and attacks many different things. And one of the things it attacks is the heart valves, specifically the mitral valve. It also attacks the brain, and you get chorea, these weird movements, and the skin and rashes and your joints get swollen and whatnot. And rheumatic fever is due to strep. So you can treat it with long-term antibiotics. But again, the one thing with rheumatic fever, and I'm going to mention it again because you need to hear it again, is its heart valve damage is permanent. Once it's damaged, everything else, the chorea, the weird movements and all rashes and joints, all of that will be resolved except the heart valve. Signs of shock in children include all of the following except. What is shock? What does shock mean? There's all types: septic shock, hemovolemic shock. Signs and symptoms: low blood pressure, elevated heart rate, decreased perfusion, decreased capillary refill. You could have your urine output stop, change in mentation. You're not getting oxygen in your brain. Again, this is something that we treat whichever way it is, whether it's giving fluids to get the blood pressure up and heart rate down. It's never hypertension, it's hypotension. Shock is not enough volume. Your body's saying, I need something more, whether it's fluids or medications, blood pressure, medicines. Which of the following is the most common cause of shock in infants and children? Think about infants. What are they susceptible to? And that's your answer. So infants, they have no immune system, right? Or minimal. So if they get an infection, they could go into septic shock very easily. Most common in children, septic shock. Multi. Signs and symptoms of rheumatic fever include, do you remember what I said? You're going to get this again, so don't worry. It's one of those weird things. The rheumatic fever is due to a strep infection that wasn't treated or not treated completely. And then what happens is all of a sudden they get, it's all upper respiratory, coughing going on. The joints get swollen. You could have rashes all over. And then I think the thing that's most concerning for parents is the chorea, which means the movements, that you can't control your own movements. Now, everything can be turned around with long-term antibiotics. It was due to a strep infection. Treat the infection, everything goes away. Except if the heart valve has been damaged, it's going to have medical or surgical treatment. It will not turn around. It's not going to go back to normal. The child just had abdominal surgery and can't cough well enough to expectorate secretion. What are you going to do about that? What's your priority? They can't cough. They just had surgery in their tummy. So when you help a child who's had surgery and they need to get up, out of bed, cough, deep breathe, use incentive spirometry, all those things, don't forget the pain medicine. Children won't ask. They don't know better. Adults, of course, are going to want their things, but children don't. So make sure that they're medicated properly, okay? Then get them up, get them out of bed, and children will do whatever you want when they don't hurt, okay? Make it fun with it. How would you position a child status post-tonsillectomy? Sideline. Okay, if we had them prone, why would we do that? We need to see their airway. We need to see how they're breathing. We want them on their side so we can still see them. If blood's coming out, it will drool to the side. They're not going to swallow, swallow, swallow. And that's the reason. And that's when they're immediately post-op and they're still really, really groggy. I worked in a recovery room too for adults. An infant of 3 months has a fever of 1036. What are you going to medicate an infant with? A 3-month-old, what can they have? So, infants less than 6 months old can only have acetaminophen. They cannot have ibuprofen until after they're 6 months old. There's something to do with the platelets and blood coagulopathy and the NSAID that infants younger than 6 months can't tolerate it. After 6 months, we'll alternate acetaminophen, ibuprofen, but before that, only acetaminophen. A critically ill child is on bed rest. What do you do to prevent complications? Now, children can have the same complications of long-term bed rest because of they're ill than adults. I mean, it has to do with nutrition and skin conditions and all these things. But don't think kids don't have long-term care because they can. So, how are you going to take care of this kid? Well, number one, we got to, skincare, right? Turning and positioning them and making sure that we keep them dry, whether diapers or chucks or whatever, making sure that they're dry. Making sure that we keep their lungs moving, right? And then we can use pillows and blankets. I use dolls and toys and stuffy animals, putting them, hugging them as they turn them on their sides and they're moving them. Kids prefer hugging an animal than they do like a pillow. It just seems more comforting to them. How can oxygen be delivered that is easiest tolerated and accurately monitored in infants? You know, there's a thing called TTN or transient tachypnea of the newborn. And it's just an infant that's healthy, fine, but has a little bit of rapid breathing at birth, a little bit of fluid left in their lungs. And what they do is they put them on a little bit of oxygen. Now, this child, put them in an oxy hood. They could suck a pacifier, suck their fingers, look around, and there's nothing taped or stuck to their face, and it's just so comfortable. It is the greatest thing to watch an infant in a little oxy hood because their eyes open and they're looking around and sucking their hands. That is the best way, and it can be given up to 60% of oxygen accurately. Okay. What procedures are used to keep the lungs open with a child with cystic fibrosis? So you have cystic fibrosis. You've got lungs that are full of mucus, really thick like Petri dish. That deep breathing, that coughing, that chest CPT, using aerosols and then doing CPT before meals, because you do it after, they'll vomit their food, and we don't want to lose any nutrition. And then, of course, the exercise. And I'll always say swimming for any sort of respiratory condition, there's no antigens, there's no allergies in the water, and they hold their breath, and it's the best thing. It's great breathing exercises. And last one here. Okay. The children with cystic fibrosis require pancreatic enzymes with meals. What teaching do you need to do to the child and parents? Remember, it's pancreatase enzymes that we give because the pancreas is not giving all of what it needs in the enzymes to take care of the fat and make it into a product that the body can use. So it's expelled. That's why the greasy stools. So how do we give it? Immediately before meals, not 2 hours before, immediately before. As I said, you can sprinkle a capsule, open it up. You can't crush it. Remember, these are enteric coated type things. Sprinkle it on the food. That's fine. And they can take that with the first couple bites. If they use the powder, again, you have to be careful about the enamel on the teeth. Rinse the mouth out when you're done. And always remember increasing the doses as these children grow. Let's see who did this one today. Number 3. Good job, Amanda. Number 2, Ash. Good job, Ash. And number 1 is, drum roll, ding ding, Kay. Good job. And Brittany and Jenna. All right, let's get out of here. All right, let's put you back and let's get you back to the PowerPoint. Any questions? Remember, respiratory is harder hit than cardiac. Most of you are like, oh God, heart, I can't stand it. Let me try to make it understandable for you. I actually like hearts. Makes sense to me, believe it or not. Really go way back to there. Can you all see that screen? Mackenzie, shake your head. Can you see that PowerPoint?
Yes.
Thank you so much. Why doesn't this wanna? Oh, give me 1 second. I'm gonna go to a different one. You can see that? Thank you. Why doesn't it wanna? Reason slideshow. All right, we'll just do it this way. I can't take it off the thing. So, cardiac. Cardiac's a hard thing because there is so much involved with it. Remember, heart and lungs work together. You got a bad heart, it's going to affect the lungs. And if you have a bad lungs, it's going to affect the heart. So just remember that. Just like hearing and speech, it's the same sort of thing. So, heart, what is it? It's a hose. It's a hose that carries blood around to the body. Okay? When you get a kink in a hose, what happens? It goes backwards because blood can't go forward. It goes backwards, right? So a garden hose, if you kink it, at the connection, you might see a squirt of water coming out, right? So it goes somewhere else, the blood flow. So in cardiac, we've got 2 types of conditions we talk about. In adults, it's all myocardial infarctions and those sort of things. In children, congenital heart defects is what we're looking at. That means that heart was born not the way it should be. That means there's not a ventricle, or there's not a valve, or there's a kink. There's something going on there. And that's congenital. They're born with it, okay?
Do you have a I only see the Kahoot page. I don't see a new.
Okay, let me do it again then. Thank you. Let me try. I appreciate that. All right, let's do it again. That's the wrong one. Sorry. Okay, do you see that now? Do you see a chapter 42? Thank you.
Yes.
Thank you. All right, it's on the other screen, not on this screen, but it's this screen, but it's okay. We'll work with it. So, types of cardiac defects are congenital, which we're born with, okay, which is some sort of the flow's not the way it should for whatever reason. The other type is that it's acquired. You see this a lot like with viral infections that get into the heart, and you have like cardiomyopathies. Um, think about lupus. Doesn't lupus attack organs like hearts? So again, that could be one of your acquired things. Now, let's look at the blood flow. It's a garden hose. Can you see the hose there? And let's talk about that garden hose. First of all, let's look at the way blood flows through the heart. Blood comes back to the body after the beat of that left ventricle. It goes back into the body, into that right atrium, right? Goes through the tricuspid valve into the right ventricle. That right ventricle squeezes and it pulls it up through the pulmonary valve into the pulmonary artery, and then it's oxygenated the blood. It comes back to the heart through the pulmonary veins into the left atrium, through the mitral valve into the left ventricle, up the aortic valve, through the aortic arch, and then it goes to the body. Now, what would happen if after the aortic arch and the three branches that you see, there's a kink, there's a narrowing in the aorta? What would happen? Blood can't go down, can it? Because it's kinked or it's minimally going down. What would you think you see if blood can't be squirted down? Well, you wouldn't feel pulses, or you would feel decreased pulses in your lower extremities. That is called coarctation of the aorta. It's a kink in the hose. So how would you know that child is a coarctation? You know, when I first started cardiac, I diagnosed one. It's the only one I ever diagnosed. And how did I diagnose it? Well, that child came out of the delivery room. I was the nurse who accepted the baby in the newborn ICU, and I evaluated it. And when I was checking pulses, I didn't feel any pulses dorsalis pedis, posterior tibial. So I went, got a Doppler, tried to listen, still couldn't hear it. What did I do next to prove it was coarctation of the aorta? I took blood pressures of all the extremities. Think about this. Blood can't go down or minimally cannot go to the lower extremities. So those blood pressures are lower. But extra blood is going back, right? So upper extremities are going to be higher. And what's going to go with all that blood that can't go down? Where's the blood going to go? Well, it goes backwards. Left ventricle stretches it, goes to left atrium, stretches it, goes back up into the lungs, fills it up, and now you're in failure. That's how it happens. So when you have a child that comes in and that has a cardiac condition or suspected, I've seen suspected a lot, they don't know what's going on, but what we're seeing is poor feeding, tachypnea, tachycardia. This child is working so hard just to breathe and just the heart to beat. They're burning calories like crazy. They're too tired to eat, so they are losing weight. They have no activity tolerance at all. They're just struggling. They can't. They're not getting nutrition, developmental delays, okay? And sometimes we can figure this out, cardiac problems possibly from prenatal history, maybe mother, father, somebody else had an issue, and that could be part of that history. Remember, poor weight gain. Why does it happen in our children with these congenital heart defects? That means the heart's working harder to make the blood go around to the body. Well, what would be a great nursing diagnosis is inadequate oxygen perfusion, leading to activity intolerance, resulting in diminished energy to breastfeed. They're not going to eat because they just have no energy to do it. So, what would you see? What the child look like? Well, we would see that they're underweight. I mean, that would be part of it. We would look at their color. We might see bluish around their lips. Some congenital heart defects have O2 saturations of 65, and that's acceptable. We want it there. 65 to 75, believe it or not, that's a hypoplastic left heart. We want it there. And I'm not even going to go in the reason why because it's crazy, but we do accept it there. Higher O2 sats would be dangerous for that child. We would look at the chest. I can feel murmurs with my hand. It's like a buzzing in your fingers. We can listen to murmurs in there. We can listen to that respiratory. As a kid gets older with a congenital heart defect with hypoxemia, just like adults, they are going to have clubbing. Infants, no, they're still too young, but older kids, yes. We're going to look at their chest. We're going to listen to things. We're going to look at the monitor, heart rates. What are normal heart rates? We're going to see cardiac abnormalities, too fast, too slow, irregular. These are all things that children can have. So once we get a kid in with these suspected, not gaining weight, all of those signs, first of all, we're going to do an echocardiogram. An echocardiogram is going to look at where blood's flowing, and that's the initial diagnostic tool that's used. Once we see an issue on the echo, we will be sending them for cardiac catheterization. Cardiac catheterizations are initially diagnostic, find out what's going on, but we can do what we call interventional or electrophysiology studies. These are things that we do in the cardiac cath. We can take a hole in the heart and we could put these devices called helix device in there, or we could have a heart that has a focus in the right atrium that makes the heart keep getting faster and faster. We can zap it with a laser, and that's EP studies, interventional, so that they're not having this tachydysrhythmias all the time and don't need meds for life. So nursing care for a child going to cardiac cath. Pre-procedure, basically infants, because I'm talking congenital hearts. This is infants. These are within the first week of life going for cardiac cath. These children, we just make them NPO 2 hours prior to procedure. Infants lose their blood sugars quick, so we will keep them eating up to almost before. Post-op, post-procedure is what we need to look at. So cardiac cath, they take 2 catheters. They put it in the right femoral vein and right femoral artery, so in the groin on the right side. And they use pretty big catheters to do what they need to do to find out what's going on with that heart. After the procedure, they pull out the catheters, apply pressure, and put a pressure dressing on that groin. There's always a chance of that clot dislodging and a large amount of blood, coming out of that infant. So these children, post-operatively, number one thing I'm going to do is check the dressing. That dressing, if it's saturated with blood, what do? I take 2 fingers, I put it above the site and apply pressure at that right femoral artery vein area, and I call for help. Again, you're trying to reclot that area where those two big catheters were. We're also post-procedure. That right leg must maintain straight. They must be on bed rest for 24 hours. You can elevate the head of the bed, they can drink orally, whatever, but that leg must maintain straight, and they have to be on bed rest to keep that clot there so it doesn't pop off. And then you see their blood glucose levels. Again, infants lose sugar quickly. We don't know if they got anything in the calf lab or only just, plain saline or ringers with no sugar in it. So we always are sure and careful with those kids. The biggest risk in cardiac cath is hemorrhage. They don't get infections. No, that's none of that. It is hemorrhage. So congenital heart defects. You did your thing on Down's children. And, I've put my information there regarding cognitively delayed kids. Down's kids, I think, got it pretty rough. Number one, these children are apt to get congenital heart defects, a ventricular septal defect, most common, and that's a hole between the two bottom chambers, the ventricles. A ventricular septal, the septum is the middle of the heart between the right and left side. It's a ventricular septal defect, a hole in the heart. Down's children are more apt to get them. And again, there's all types of Down's children. The numbers I've seen a 9, a Down's 9, which was severely problems, had only one ventricle, couldn't breathe, had a trach, was on a ventilator at home. I mean, this kid was very, very severe Downs. We usually see 18, 21. Those are usually the ones that we think about. So congenital heart defects. I'm going to explain something with pressure, all right? Whenever you have high pressure, it wants to release and go to a lower pressure, right? Think about it that way. Think about the right side of the heart and the left side of the heart. The right side, blood just gets back in there after going all the way around the body, and it just gets back. So there's very low pressure there. The left side has 4 pulmonary veins putting blood in there. So pressure is very high. So what would happen if there was a hole between the upper chambers? We have a patent foraminal valley that's born at birth, right? That hole that closes eventually. Sometimes it doesn't. If there's a hole in the heart, it's always the pressure is going to take it from the left side to the right side and go back in the lungs. And we call that increased pulmonary blood flow because you're sending the blood back and back and back into the lungs. So it goes out of the lungs, down the left atrium, back into the right atrium, right ventricle, back into the lungs. Increased pulmonary blood flow. And that's what we call right, left. It's from areas of great and least resistance. It's when you have big pressure, it wants to go low. Now, there's all sorts of defects. Here's that increased pulmonary blood flow. Didn't I just tell you about that? ASD and VSD goes from left side to right side. There's a door open, it can get there, it's going to go there. There's another thing here called a patent ductus arteriosus. This is fetal circulation. This is something I'm going to go into meds on how to treat it, okay? But whenever we have a heart that's not getting oxygen to the body, we need to have a way to get it there. And our oxygen giver is a patent ductus arteriosus. It connects the lungs to the aorta. So you're getting oxygen right to the body. So it's an oxygen giver, okay? That's all you need to know about that. Obstruction of the blood flow, I already told you about a coarctation, right? It's a kink in the hose, it goes backwards. Stenosis, what's a stenosis? It's a narrowing. An atresia, A means without. There's no opening. So decreased pulmonary blood flow, tricuspid atresia, there's no connection between the right atrium and the right ventricle. I need an oxygen giver here, don't I? That one's going to have a PDA open. The most tested of all of your diagnoses is tetralogy of Fallot. Ever hear of a tet smell? Baby turns blue. Well, what happens in tetralogy of Fallot? Your pulmonary valve closes, it kinks, or it gets tissue stuck on it, and no blood can go from the right side into the lungs, which means the baby's not getting oxygenated. I had Mr. Nolan Ryan, this is my baby, I'll never forget him. At 4 or 5 o'clock in the morning, I was, straightening them up, changing them, making them pretty for mommy and daddy. They were just about to wake up. Kid hits a tet spell. He went from O2 sats of 100 to 10. I mean, within a minute, he went from pink to black, blue. It was scary. What do I need to do if a child has a tet spell in front of me? That pulmonary artery is kinked. No blood can get to the lungs. We do what we call a knee chest. Whether it's an older kid who squats to the floor and does it, or as a nurse on a baby, I take their knees and push them to their chest. Whether they're on their back, I push their knees up, or if they're on their side, I push their knees up to their chest. What does that do? It takes the pressure from the abdomen and the chest cavity and changes it and pops open the valve, and it lets the blood reflow. There's other things, morphine we can give, absolutely, but that is tetralogy. It is 4 things that happens with it. It's all right-sided. There's going to be that pulmonary stenosis because it closes sometimes, that right ventricle stretches, so right ventricular hypertrophy, which means a stretched right ventricle. And it also, there's a hole in that lower chambers, a ventricular septal defect. And because of that, the aorta overrides, is what it just pushes over there. So that's tetralogy. And then in cyanotic, I'm going to mention transposition of the great arteries. This is when the pulmonary artery and the aorta, they're switched. They're switched. That means you have systemic blood and pulmonary blood, and they're not mixing. That's transposition of the great arteries. So we need an oxygen giver, don't we? We're going to keep that patent ductus arteriosus open. Fetal circulation closes at birth. Within, they say up to 21 days. I'm going to say in 2-3 days, usually they're closed, usually that quick. So this transposition needs us to keep that PDA open, and I'm going to show you how. And then I'm going to mention, because it's the most severe of all of them, hypoplastic left heart syndrome. Your left ventricle is born and there's no muscle, it don't work, blood don't flow around. And it's a 3-stage surgery. It's a lifelong care. So PDA, you need it. I need oxygen. I have a transposition of the great artery. I have no connection from my right atrium to the lungs. I have tricuspid atresia. I need my oxygen giver keep open because mommy in utero produced prostaglandins, a normal, a natural hormone, and it keeps that little duct open. But baby's born, mommy goes away, there are no more prostaglandins being formed. So what do? We have synthetic prostaglandins that we start on them, a slow, continuous infusion. And what that does, it keeps open the PDA, and it gets oxygen from pulmonary artery to the aorta. It gives oxygen to the body. And it gives us time, a week or so that child get a little bigger before we do this arterial switch operation. It's a huge, huge surgery. So when we have a PDA and we didn't open it, and it's just kept open, I don't know, I guess there's some little extra prostaglandins, floating around in the body, and it still keeps open. I see this a lot in the younger, smaller, like 20 some odd week premature infants. Their PDAs don't close. So how do we say, hey, prostaglandins, go away, let it close. We want blood to flow normally. Well, we give indomethacin. It is a medicine. It's a medical closure, and we give 3 doses. And what's pretty neat, what I loved about giving indomethacin is a PDA, you hear this washer machine murmur. You can hear it. As you give indomethacin, the murmur goes away. So you know it's working. Sometimes the medical doesn't work and you have to go with a surgical repair. It's a thoracotomy. It's not an open chest. It's on the side. But most of the times, indomethacin will take care of it. There's a couple pictures here. You can look through them. I'm not going over all of them. I think I've described them to you. But if you want to look at them closer, there they are. Now, big concept in cardiac is you need to understand heart failure. Congenital hearts are going to go in failure. You need to know what to do. This is the big thing in cardiac they want you to know. So what is heart failure? It could be that coarctation, kink, blood flowing up into the lungs, and we're in heart failure, right? It could be that. It could be that heart muscles damaged. It could be many different things. But what do we see? Well, these children are going to be in, heart failure. They're going to have sudden weight gain because they can't get rid of fluid. It's filling up in the lungs, right? They're going to become tachypneic, tachycardic. You're going to hear this fluid in this lungs going on. Blood pressure is going to go down. Heart rate's going to be up. These are things, congestive heart failure. So what is our goal? Well, as I said, it's fluid in the lungs, it's heart failure. The heart can't squeeze it out and get it around where it needs to go for the kidneys to get rid of it. So we got to do it. So we're going to do something to get rid of the fluid. Furosemide, simple diuretic, easy, and digoxin. Slowers and strengthens the force of contraction, squeezing that heart, making it work better, giving those diuretics, get rid of the fluids. And we know that they're getting better because they're going to lose weight and they're going to be able to eat better. They're not going to have tachycardia and their blood pressure is going to be better. Now, we talked about digoxin. I gave you that one question in the earlier Cahoots. So digoxin, remember, just like adults, apical for 1 minute, check potassium, check dig level. In infants and young kids, the only sign that you might see of cardiac, of digitoxicity might be just vomiting. If you have an infant on digoxin who's vomiting, I personally, I'm going to hold the dose, call the doctor, and get a dig level drawn. It's better to be safe than sorry, okay? Hypoxemia, that little hypoplastic heart with O2 saturations of 65%, it's going to cause hypoxemia, right? What does the body do when the O2 sats are not normal? It says O2 is carried how in the body? Red blood cells. When you don't have oxygen in the body, it says, let me try to help you here. I'm going to produce more red blood cells so that you can carry more oxygen around. There's no more oxygen, but they still produce more red blood cells. So what happens? Polycythemia. You're going to see hemoglobins and hematocrits of 18, 19, normal on these congenital. Hypoplastic left hearts are always 16, 17, their hemoglobin. It should be 12, 14. I mean, it's quite significant. Just the body trying to help. So care of the family and the child. Again, it's always teaching as you do things. Let them know what's going on. I think cardiac families are amazing. They are really wanting to know because these are lifelong conditions, many of them. We went over the cardiac cath already. Endocarditis, just like adults, what do? We give prophylactics before. If we're just finding it out, of course, if it's a bacterial endocarditis treatment, long-term antibiotics. Here's rheumatic fever. Let's go over it carefully. Some questions on the exam. You got to know this one. So what is rheumatic fever? Rheumatic fever is caused by a strep infection that was not treated or it was undertreated, okay? This requires antibiotic long term. And as I said, that inflammation of the joints, the skin, that chorea, all of these things will go away. Okay. So some of the symptoms you see is, of course, you have a sore throat. You're going to see joints swollen. You might even see rashing all over. You're going to see that chorea, that brain, I can't function and work. And again, everything can be reversed except if that valve, the mitral valve, is damaged, it is damaged for life. It'll be medical or surgical treatment. You know, kids can get hypercholesterol. You know, years ago we didn't check them, but we found out some do. So we want to check them as kids, preventing things when they're older. Kids can have all the dysrhythmias as adults can have. Okay. I've seen a pacemaker. The youngest kid was 18 months old. And so it's possible. Pulmonary artery hypertension. This is a concept of too much flow going to the lungs for long term, and the lungs say, I'm going to protect myself. I'm going to clamp down. I'm not going to exchange oxygen, carbon dioxide. That's what pulmonary artery hypertension is. So if I'm clamped down and I'm not allowing exchange of oxygen, carbon dioxide, what symptoms would I show? Well, I'm going to be dyspneic at any sort of exertion, right? Because I'm not having oxygen because my body, my lungs not allowing it. And because of that, you might have chest tightness. You're not getting oxygen. You could be dizzy. Cardiomyopathy, I said, is can be due to many different things. Many times we treat them, and then all of a sudden it gets to the point where the heart's so stretched, so big, we need to do a transplant. You know, rejection is the largest reason for death. Okay? Rejection. Chest tubes are common in cardiac kids. Whenever we do a procedure on a child, whatever it is, be honest with if it's going to hurt or not. Now, chest tubes that are pulled out burn, but it's not long term. It's like an instant burn, and then the pain goes away. I know this because I did adult open hearts also. So with children, how do we take out chest tubes? Number one, you're going to, of course, get on the level of the child, explain the procedure. You're going to make sure they're pre-medicated. And you're going to be honest. It's going to burn. It's going to hurt for a second, even with medicines. But you're going to do the best you can to make it as little as possible. That's always the priority. Honesty. Kids will not forgive you if you lie. We're also doing blood pressures on kids younger and younger today. We're finding them. Again, we're preventing renal disease and whatnot by doing that. Kawasaki disease, interesting. This is, again, a systemic vascularitis. It's not an infection. It's an inflammation of blood vessels, okay? We don't really know why it's there. Our biggest concern with these vessels being inflamed is the coronary arteries, worrying about an aneurysm. That's the biggest concern. These kids, they're very distinctive if they're full-blown Kawasaki. Their eyes are red. I mean, red, like they stuck their fingers in their eyes and are really irritated, and even more red than that. They glow in the dark. That's how red they are. Their lips and tongue, strawberry. And you might see swollen glands. The other distinctive, the palms of the hands, soles of their feet can crack or blister. Okay? So how do we treat it? It's a virus. I'm worried about the vessels of our heart. We got to take care of it. So what do? We give aspirin, high dose. Only time you're going to see me say aspirin for a child. Why do we give aspirin? Because it thins the blood. It prevents clots. And it's vascularitis, which could have microembolus everywhere. Okay? And to boost the immune system, we give IVIG. Okay? We know about COVID. We know that we're giving those immunizations. I mean, I think of one thing that we know a lot about COVID and how it affected us. And look at that. Treatment is similar to Kawasaki disease, IVIG. Shock, we've talked about it. Children, the most common is that septic shock. We know kids are more apt for anaphylaxis. Kids, the first time we're giving an antibiotic is when they're kids, right? And this is sometimes where they can go into anaphylaxis. So if we're giving a new drug to a kid that's never had something, stick around and make sure that we're watching. Septic shock, we know, again, all the signs of symptoms. That is low blood pressure, a high heart rate, decreased urine output, prolonged capillary refill, restlessness, hypoxemia, right? These are things. How do we treat septic shock? Antibiotics, treat the sepsis, and of course, fluids or whatever medicine to keep the blood pressure up. Adolescents, tampons, toxic shock syndrome. It's one of the things they can get. So, question here. Surgical closure of the patent ductus arteriosus would result in what? So, PDA connects the aorta to the pulmonary artery. So we closed it. What's going to happen? You can't have any backflow back to the lungs. It's just going to be now just blood flowing with oxygen to the body. All right, let's go to our last Kahoot. We're doing good on time today. One second, I'm getting there. Right. There we are. Can you see that? Thank you, Mackenzie. You're my thumbs up girl. I think there's 17 questions here, not so bad, and we're right on time, so we did good. Because this is a big week of information. Remember, after class at 5 o'clock is when we do open the quiz. That quiz, remember, it's still, timed. It's due by Sunday night, okay? So whenever you feel you're ready for it, it's open and ready for you. So at 5 o'clock, it opens up. Some of you like to do it right away. Some people wait. Whatever works for you. Does anybody want to join me? Let's just get going. Kahoot. Why would a child with tetralogy of Fallot not gain weight at the normal rate? Tetralogy of Fallot is pulmonary artery gets closed off and blood can't flow to the lungs. They're tet spells. They turn blue. Usually they're taken care of as infants, but sometimes they get to be older kids before they're repaired. And these kids naturally, they're having a tet spell, they squat. All of a sudden you'll see them squat, and it does the same thing as a knee chest. So again, tetralogy, you're not getting oxygen. You don't have oxygen, you have no energy, you're not going to eat, you're not going to gain weight. That is big concept in cardiac. Other multi, a clinical manifestation of Kawasaki disease. I remember when our director of the cardiac ICU's son came in with Kawasaki disease. That's the first time I had ever seen it. His eyes were as red could be. Again, it's the hands, the palms, and the soles of the feet, blistered, cracked. It's that tongue, it's the lips, it's the eyes. Korea is rheumatic fever. Good job, guys. I've never had a class, not one person picked that. Good job. Which of the following best describes the pathophysiology of Kawasaki disease? What do they tell you it is? Why do we give aspirin? Why am I worried about aneurysms? What is Kawasaki? So Kawasaki is just the blood vessels. It's a vascularitis. So you have inflammation of the vessels. Our concern is microembolus. That's why we give high dose baby aspirin. Sometimes they're leaning now more towards Coumadin, but then you have to do all that testing. So they're baby aspirin. It's either or, but usually it's baby aspirin and IVIG. What is the treatment for Kawasaki? So Kawasaki, aspirin for the clots to prevent clots, IVIG to boost immune system. Why do you give aspirin to a child with Kawasaki? That was a Hesse question. One of the students told me. Well, what is aspirin? Aspirin's an NSAID, right? So it does have an anti-inflammatory to it. That's part of the vascularitis that we're trying to get rid of. It prevents clots and it thins blood. So it is used for all of those. An abnormal hole between the right and left atrium is called what? So you have atrium and ventricles and septums in between and valves. What is it called? It's called an atrial septal defect. Atrium is the top. It's the top part of the heart. It's the atrium. So it's an atrial. And it's the septum or our septal. Atrial, septal, and it's a defect or a hole. What is the treatment for tet spells? You have a kid have tet spell. What are you going to do? So when a kid has a tet spell, their pulmonary artery closes up, blood can't get to the lungs. We need to do something, change the pressure, so that we can pop open that so we can get blood flowing. And it's either the kid knee, the knee to chest, or the older kids, they just all of a sudden they'll squat down on their knees, and it works that way too. Multi. Why is prostaglandins given to a child with transposition of the great arteries? Transposition means the aorta and the pulmonary artery are switched. It means there's oxygen here and there's no oxygen here, but there's no connection. So prostaglandins is for that patent ductus arteriosus, or PDA, which is my oxygen giver. So yes, it helps with oxygen. And because now the heart is flowing as oxygen, it increases cardiac output. Has nothing to do, it's not an infection thing. It's a prostaglandin is a hormone that keeps this open. It's not anything to do with infections, has nothing to do with endocarditis, none of that stuff. All it does is keeps it open. Your fetal circulation is maintained. That's all it is. What is the purpose of giving indomethacin to a neonate with a patent ductus arteriosus? What does indocin do? Indomethacin. So indomethacin closes the PDA. This is when you'll have that young, small, premature infant that still has that PDA open. And we don't want to do surgery on a little 1 pound baby, right? So we can give them indomethacin. And it's an IV, it's 3 doses, and you can listen to that murmur go away. It's really great to watch. Transposition of the great arteries. Aorta and the pulmonary artery are switched. Again, transpositions, they're transposed. That's what it means. Again, this is one that at birth, as that PDA closes, this child's going to turn bluer and bluer and bluer. I remember one baby that we went down to Colombia, the country, to go get and transport, and they didn't have prostaglandins in Colombia. So we hauled our down there to get them the prostaglandins and get that baby up. And actually, the baby did very, very well once it had prostaglandins. In fact, the kid didn't need to be intubated, none of that. In fact, was eating a bottle because the kid was fine because it was oxygenated, because everything else was okay. And then we waited a week and then we did surgery and the kid did well. When measuring blood pressure on 4 extremities of a child with coarctation, what would you expect? That's the kink in the hose. The aorta arch and the aorta, it's kinked. What would you see on blood pressures? I got little flow going down and too much flow going up. So blood pressure is going to be lower in the legs than the arms because there's no flow in the legs. It's all going up. You might even see, distended jugular veins. Older kids, you might even get nosebleeds if they're an undetected coarctation. Headaches. This could be all coarctation. Something to look at. Early signs of heart failure in infants. What do you see? Infants. So when you see a kid in heart failure, number one, you're going to see a sudden weight gain, right? Because the fluid's not going anywhere. And then they've got all this fluid in their lungs. They're going to be tachypnic, they're tachycardic, they're going to tire easy. So it's poor feeding, and they're going to be sweating like crazy people. They're working so hard just to breathe and swallow. So that's they sweat with that also. Multi. Signs of heart failure in a 3-week-old with congenital heart disease. So, heart disease, we're going to see weight gain, not weight loss, usually because the heart's not beating effectively, which means you're going to have swelling. And with that, tachypnea, tachycardia, because all this swelling, all this weight gain, and hypotension. Absolutely. Cool extremities. Feeding the infant with heart failure. Got a kid who can't breathe. Heart's not working. They tire easy. How are you going to feed them? Because nutrition, nutrition, nutrition. This here is a huge concept. When we're talking about cardiac children, it's congenital. What do we expect? So we have a kid, an infant, that heart's not working effectively. It's not squeezing what it should. So if we hold that child up, so we got that good airway, diaphragm down, okay? Sometimes we need to let them feed a little bit and then lavage the rest so they don't tire out, but they still get their nutrition. The other thing, which is pretty cool, formula or breast milk is 20 calories per ounce. Okay. We can increase it to 30 calories. So it's 1.5, and it's smaller quantities of fluid. So they're getting the nutrition with less effort because it's less quantity they have to swallow. Okay. Also, we will be monitoring for all the signs of tachypnea, diaphoresis, and vomiting, and making sure that we're not overtiring them. After a heart transplant, what's the leading reason children die? Rejection, rejection, rejection. That's why they're on anti-rejection medicines for life. Nursing care following a cardiac catheterization. Remember, we've put a hole in the right femoral artery and vein. And our biggest concern will always be bleeding post procedure. So make sure you assess that site for hematoma. What if you go in and the first thing you do, you look and you see that there's blood on the dressing and it's bleeding? 2 fingers above the site, apply pressure, call for help. Where is a patent ductus arteriosus? What is it? What does it connect? I've said it about 5 times. It's an oxygen giver. So how does it give oxygen? It connects the aorta to the pulmonary artery. Pulmonary artery is oxygen to the body. Aorta sends oxygen to the body. Oxygen giver. What is a sign of digitoxicity in infants? So digitoxicity. Adults, same thing, right? Adults see yellow spots, but an infant doesn't tell you they see yellow spots. The only sign you're going to see is that vomiting and, of course, a low heart rate because digoxin slows the heart down. You might see the infection has nothing to do with digoxin. What are the signs and symptoms of heart failure in children? What would you see? It's going to be gaining weight, edema, fluid. Heart's going to have, palpitations, shortness of breath, tired, not eating right, etc. It's a whole big thing. These poor kids. Which medication is commonly used to relieve the spasm during TET spell? How do you relax the heart? Morphine. During a spell, it's morphine. For every day to prevent, it's digoxin. Good job. Preventing post-op complications. Last question. So if we get a kid up and moving, what are we doing? We're preventing DVTs. We're preventing pulmonary complications, getting them up, getting them out, and getting them moving. Ambulation is important. Yes, we're going to use pain management. Yes, we'll keep them hydrated. Yes, we'll give them those antibiotics. But if we do all that and we don't get them up and moving, they have other complications. That's why that's the answer. Number 3, Brittany. Good job, Brittany. Number 2, SK again. Good job. And number 1, Ash. Good job, Ash. Number 4, Mac and a Joy. Good job, guys. So that's all I got for today. Remember, next week we're going to be starting our reviews. Anybody who wants to see me regarding their exam, let me know. I can do it tomorrow. I can do it on the weekend, whenever you want. Scores were, all over the place. We did give back several questions to let you know because they weren't fair, as according to us. So we did do that for you. But please, anybody who didn't get a 78, please come see me. And I want to get you prepared for the next exam. Exam 2 can be tricky, and I don't want you to be left behind, okay? Any questions?
So you want us to email you or?
Send me a message. Yes. Send me when you can. I don't like early mornings. That's the only thing I don't like.
Okay.
Thank you. All right, guys. Have a good one.